Hello, Assalamu alaikum. What's up, everyone? I'm Dr. Asif. Today, we are going to make a new video regarding the neck and spine. You already know that I was been absent in the past few months because I've been affected with COVID-19 and been admitted to the hospital for 1 month at least. So moreover. So now there is some collateral problems. That's why I didn't make any videos in these days. So now you can see here that I am been here for with the new setup. So after that I'm going to continue the post tutorial videos about the belly lobes, and later on there will be different kind of videos regarding the surgical training for surgical trainees, but also for the other healthcare providers. So let's start. So today's topic is the neck and spine. It is also a part of a trauma chapters. So let's continue. So I'm Dr. Asif, Assistant Registered Surgery. Let's begin. First, I'm going to describe in short about the anatomy of the spine and spinal cord. That is the vertebral column that is supposed to be the midline skeletal structures that composed of series of motion segments. The motion segments consist of different adjacent vertebrae, intervertebral disc, ligaments restrain, and upper cervical spine anatomy is designed to facilitate motion and stability. Here is dependent on the ligaments restraint because spinal cord is stayed in the positions with some ligamental supports. Okay. Here the upper cervical spine that is also facilitates some movements, and also the lumbar region, that is cervical and lumbar region is little bit movable or parts, but the thoracic sacral region is somehow fixed or little movement dependent. Okay. Here you can see two different pictures. That is here the spinal cervical part, which consists of some bodies and arch, pedicles, and there's the intervertebral foramens here, and these are the intervertebral discs. Okay. And here if you see a 3D image of a segments of a cervical spine, so you can see not only for the cervical spine but also for the normal vertebral region. Here the number 1 lumbar vertebra, it is a 2, but in between 2 there is a segment which is called the intervertebral disc, composed of nucleus pulposus in the central and the annulus fibrosus in the periphery. And here you can see there is a foramen which is formed by the upper and lower vertebra, that is also called the intervertebral foramen. And here are some ligaments. that is anterior, middle, or middle or posterior. If that is so, then the spinal stability will be hampered, and the spinal cords extend from the foramen magnum to the L1 to L2, where it ends to the conus medullaris in the medulla in the lower children, because it is a question how long the spinal cord ends, because in case of adult it will end in the lower border of the lumbar 1, but in case of children where the bones are not matured, where the length of the column is just under the developmental process, in that case spinal cord level and the column level will be the same, that is lumbar 3rd to 4th. Okay, the lower level will be lumbar 3rd to 4th. So and the other parts, the surrounding parts, will consist of conus medullaris. Okay, so here you can see the columns, that is anterior column is that portion, middle column is that portion, and the posterior column lies much posteriorly. So this is the 3 columns. Now here you can see a segments of spinal cord. Okay, so here you can see the lumbar 1 hair cord, then the branches, this is called the conus medullaris, and the remaining portion or branches is called the cauda equina. And here the cross section of spinal cord, what you can see, this is the lateral column, there is a dorsal column, this is the ventral column, so there are 3 columns. So in these columns there are some different kind of nucleus or center, that is a fasciculus gracilis here from the very much dorsal column, cuneatus or gracilis, that is called the posterior part. Okay, that's the dorsal part. It is mostly related with the sensory functions, that is proprioceptions, pain, vibration sense, temperature sense, like these are the dorsal column. And the lateral column is called the corticospinal tract. This is also called the motor fibers. So motor fibers are composed in the lateral corticospinal tract. And the lateral spinothalamic tract along with some ventral fissures, these are also important with the sensory functions, that is ascending tract. All the ascending tract come from the ventral column, that is spinal thalamic tract, and the lateral part, the lateral corticospinal, that is also called the pyramidal or extrapyramidal fibers. Okay, those are involved with the motor functions or present in the lateral corticospinal tract. And the dorsally, that is in case of dorsally, you can see the fasciculus gracilis, cuneatus, and the tract of Gall, tract of Budak, that you all know. Okay. Now the clinical anatomy regarding this spinal cord. The lateral spinothalamic tract transmit the sensations that I already said that. Here you can see corticospinal tract is the motor fiber functions, and the spinothalamic tract cross the opposite side, because sensory fibers are decussated, that is decussate. It will, if I feel touch here, so these fibers will go through the spinal cord and it will cross the side and distribute it to my left sided procedure, because if there is a lumbar injury or below this, we all know that bowel and bladder habit, which is controlled by nervi erigientis. It is also called the pelvic splanchnic nerve, that is largest, or the sacral parasympathetic component. So in that case, if that portion is injured, patient's bowel and bladder habit is impaired. Okay, and you can see some neurological examination. The American Spinal Injury Association neurological evaluation system is an internationally accepted method of neurological evaluation. So neurological evaluation is very important because we need to check the sensory and motor functions of the leg and the abdomen and the thigh, skin and muscle supplies must be checked. Here you can see a spinal roll. Some people will trying to roll the patient, and you can see that association has made a scale, that is Frankel classification of spinal injury, A, B, C, D, E, that is complete spinal cord injury. B, sensation present or motor absent or not, sensation present, motor present but not useful. Sensation is present, motor is useful, normal functions. So this is the most severe part, that is complete spinal cord injury. Then is a less severe, is called sensation and present but motor is absent. Then sensation is present, motor is also present but not useful, like that is mildly present, and sensation present, motor is also present and normal. So this is the grading of his spinal cord injury. Okay, now the physical examination, what is that is we will assess the spinal cord injury by the Asia Neurological scoring system, that is it, and the 3 shocks, if there is any spinal shock present or not, and the motor supply. This is the ASIA criteria, because it is a checklist. After each examination we will make a sign here for prognosis. Then we will calculate the marks or points. How was the scoring? Then we will assess the scoring system. Now what are the investigations that we can make? That is plain radiograph. It is very much cheap and available tests all over our country, not only this country but also all over the world. So that is very much popular. Plain X-ray or lateral view, plain X-ray, cervical region, lumbar region or thoracic region, and we can make a lateral view to see the segments or intervertebral segments. Here you can see some cervical regions X-ray. This is the alignment, and you can see there is a fracture here or displacement of the vertebral body. And you can see, if I see from the above, like this way, the body is already fractured and the pedicles is already separated. Now the MRI is the second choosing investigation. The lateral flexion extension radiograph of cervical spine should not be undertaken acutely, though they can have a role in assessing spinal stability in the longer term. We will try to assess the pain, then surgery is necessary. The indication of operative intervention is influenced by injury pattern, level of pain, degree of instability, and the presence of neurological deficit that I already said. Now the decompression and neural elements. Okay, the realignment of the spine and the correction of the spinal deformity may achieve an indirect compression. If there is an indirect compression, in that case surgery can be necessary. Some injuries may be resolved temporarily by corticosteroid. Like corticosteroids are no longer indicated in the acute spinal cord injury because of lack of evidence of support. Steroids do have a role non-traumatic spinal cord compressions, like malignant spinal cord compressions. If there is a malignancy like multiple myeloma or a lymphoma or any osteosarcoma or metastatic disease of the bone, in that case corticosteroid might not come any help. Okay, it will causes wound dehiscence or postoperative wound infection and sometimes hyperglycemia. So in that case we need to stop sometimes to make a good outcome. Here you can see management. So neurological deficit determines the management. If the neurological deficit is not present, in that case we will go for conservative management. If neurological deficit comes to the contact, in that case surgery might be needed. So deterioration neurological status, that is neurological status, requires surgical interventions, and corticosteroids are ineffective. In that case, ineffective. Now, what are the other most diseases or most injuries that we can see in the daily life? That is occipital condyle fracture, odontoid fracture, traumatic spondylolisthesis, that is hangman fracture. Then occipito-atlantal dislocation, atlas fracture, fractures in the patient with ankylosing spondylitis, atlantoaxial instability, then thoracic and lumbar fractures. These can also occur in nowadays. Now the spinal cord injury, that is spinal cord shock. Here we will discuss about the spinal cord shock. That the spinal cord contains various tracts that are topographically arranged. Spinal cord injury involves both primary and secondary phases. Therapeutic strategies are directed at reducing the secondary injuries. The second thing is the incidence of spinal cord injury remains constant because it's not reducing, but because accident is usually occurs nowadays. So spinal cord will also comes through the same weakness, and the outcome is improved in regional and national spinal cord injury centers, because like our country there are different institutes about the spinal cord, like spinal cord center, trauma care center, so emergency trauma centers, or there are some branches in the neurosurgical units about the special care about the spine surgery. In that centers there are some outcome strategies, and which is very much helpful or very much helpful also. Pathology of the spinal cord injury, that is, this is the direct insult to the neural elements, and the osteocord syndrome, cauda equina syndrome. It is also common here in the elderly ages, and these also are very much common in RTA or any accidental injuries. Okay. So now at last, what are the complications associated with the spinal injury? What are the complications? So pressure sore, that is pressure ulcers, already been seen, and neurological deterioration, that is nerve involvement, pain and spasticity, thromboembolic events, because neurogenic shock or spinal cord injury can causes thromboembolic complications like deep vein thrombosis, like saddle embolus, like thromboembolic occlusion, osteoporosis and contracture. In elderly female, some are complained about the osteoporosis and the autonomic dysflexia, that is reflex will be autonomic. Thank you very much. So that is all about the trauma. So this is the neck and spine chapter from the belly labs. So I hope you like the videos. After a long time later, I just started to make this video ongoing. So thank you very much for patience hearing, and at last I like to request you to subscribe and like my channels to see the next videos. Thank you very much, and thank you very much for patience hearing. So another things I need to ask that if you have any question regarding the lectures, or if you think that any segments I didn't understand, so you can comment there in the comment box, and also you can ask me to my Facebook account, that is Virtual Medical Blog and Surgical Classroom. So there is a group that is Virtual Medical Blog and Surgical Classroom, so you can go there, and also you can find out the solve or discussion regarding the videos. I can show you here the long-term effects that I can see there. Let me show you. See what. So this is my groups. You can see here the Virtual Medical Blog and online classrooms. So this is my group. So all the lectures will be provided here as a copy, and also you can connect me and you can ask questions here, and you can have some comments here. Okay, thank you very much. Thank you very much for listening. Peace.